There we go. Hey everybody, welcome back to this week's episode of the GoliCast. My name is Bilal, I'm one of the 4 hosts of the GoliCast. I'm sitting on my carpet because it's really cozy. Also, there's a video playing in the background of a BMW. It's gonna be like that for the next 8 hours. In case people are distracted by me speaking, there's stuff happening in the background. Using my sword as a microphone. I also have a separate mic over there under the table. So it's just so I don't look really awkward, but that's picking up all the sound. How's everybody been? I can't hear you. It's been a while since the last video, the one about love and relationships. A pretty hot take. I had a lot of opinions in that one. Some of you agree, some of you disagree, but that's the whole point of having a conversation. This video might not be for everyone. It might be more specifically for some of my friends who are studying medicine or who want to know a little bit about the NHS. I want to talk about my first year as a foundation doctor, or in my residency program in the UK, which is the US equivalent. Before I came to the UK, I did an internship in my second last year of medical school in the hospital I currently work in. That's a really good point of starting. You need some type of NHS experience as an international medical graduate, which can be shortened into something called IMG, not image or PNG or whatever, JPEG, someone who studied in the UK. So we can't directly apply into a 2-year foundation program. We have to apply separately as something called a clinical fellow. Fellow sounds kind of weird, but that's the word we've been dealt. So UK experience is really good. Try to get an attachment done before you apply for any type of clinical fellow job. Thankfully, this hospital that I work at also does clinical fellow jobs at an F1 level, which is the starting point of a new doctor in the NHS. You can also, a lot of other places also take clinical fellows, but they take you at an SHO level, which is a senior house officer, or an F2 plus level. It's been exactly a year since I've been living in the UK. I'm pretty British now. My accent is still terrible. In the F1 year, given 3 rotations, don't get to choose them. They get handed to you, at least for the IMGs. You apply for a job, you see the job ad, it gave me these 3 rotations, and those are the ones I did. Usually it's 2 medical ones and 1 surgical one, which is what I had, and I'll be talking a little bit more about that. So I started in September. Mind you, despite doing an internship beforehand, I didn't entirely know how to use all the systems, how to use all the protocols, how to use all the guidelines. All I had was the knowledge in my head from med school and a little bit of clinical skills that I learned while I was in med school. My first job was something called acute medicine. And man, was that chaotic. Imagine your first job as a doctor is something in the realm of not entirely A&E, but medicine, where everyone is really sick all the time. The beginning was really tough. I would never finish on time. There was not a single day when I was in acute medicine that I finished the time I was meant to finish. I was either at least half an hour late, just because the amount of work I had. Acute medicine is a rotation that is very much consultant-led at an F1 level. Always either with a consultant or with a registrar. The way it works here, the take is something called clerking, or in other simple words, admissions. So the take doctors, it could also be an F1, F2, anyone all the way up to a registrar, admits people that come through A&E or come through GPs. You admit them into a hospital, meaning you're the first doctor they'll see, do something called clerk you or admit you. So they note down things like your medications and your past medical history. They'll speak to you, what symptoms you have, and they'll give an initial impression of what they think brought you into hospital and what they want to treat you with. As the acute medicine F1, you're going on something called a post-take. So the take was the admission, post-take is now they need to be seen by a consultant. I was always with a consultant. The consultant would go over the history given by the clerking or the admitting doctor. All the same results and things again on the computer. We have different systems on the computer. We have something where we look at observations, something where we look at the medications, and something where we look at blood tests and request tests and things like that. Consultant then takes you, a junior, with them. It's not simply, you're not a pen holder, even though a lot of people make it out to seem that way. You can ask a lot of questions. They ask you questions. They ask you, what do you think about this ECG? What's abnormal on these blood results? What would you make of the impression from the clerking doctor? A lot of acute medicine is something called post-taking. You post-take in different departments, emergency department, the acute medical wards, where people stay for a limited amount of time, maybe 48 hours up to 5 days maximum. Or that's the ideal situation, before they get moved to the other wards, so the specialist wards, so geriatrics, cardio, respiratory, whatever. As much as I knew the theory behind a lot of these diseases, I didn't know many things like the common medications we use here, the dosages of said medications, the procedures we have to do for a lot of sick patients, things like lumbar punctures, acidic taps. The learning curve there and the expectation to do certain jobs, like requesting scans and things, was okay. I got a hang of that. But like speaking different specialties, filling out referral forms, that's something that gets used to because it's different from different trusts. A trust is just a name for a series of hospitals, and here most of the hospital come under the umbrella of an NHS trust. Acute medicine kind of went on like that for 4 months of just literally post-taking, and occasionally you'll be clerking, aka you'll be the admitting doctor. But you have a lot of consultant support, even though it can take a toll because some consultants are nicer than others. Some expect more from you, some expect less. I feel like it really pushed me to learn a lot of medicine, which I feel like I learned a lot while I was in acute medicine, which was really good, especially having your SHOs around, so your senior house officers around, registrars around. Even when the consultant leaves, there's always someone you can turn to. There's also had a lot of emergencies, meaning something called an emergency call or something called a MET call. So the medical emergency team shows up when you put out a MET call. When you're worried if someone is becoming unresponsive or someone is really unwell or someone's really sick, you do double two, which is universal in all of the NHS. And I'll put out a MET call. So there's a MET team. MET team is made up of 2 registrars, one handling the take admissions, one handling the wards, a long day F1, an SHO, someone from ITU, someone from Outreach. Outreach is a specialized nursing team for really sick people. Airway support or general support. So if you're feeling alone, you can always put out a MET call if you're worried someone is really sick. But obviously you shouldn't put out a MET call all the time. It's really good to listen to the nurses. If you're unsure, the nurses have been in this situation before. As a starting doctor, a lot of times they do it, and I heavily support nurses. And you don't underestimate yourself. Sometimes nurses might not be around, and if you're worried about the patient, you can put out a MET call. I never had to do that in acute medicine. I was always with someone who would already put that out if someone is really sick or starts deteriorating. So the way we track people being sick is something called the NEWS score, which is the National Early Warning Sign. So that would include things like their respiratory rate, their saturation on either air or oxygen, blood pressure, heart rate, temperature, any of these things, or like their mental status, so whether they're alert, confused or whatnot. Any of these things go out of whack, they start scoring high. Scoring high is worse, scoring low is better. If someone is like using a 1 for something, like their SATs are slightly low, and then now they're still using like 10, their SATs have dropped, they're on like 10 liters of oxygen, the respiratory rate is going up, they're tachycardic, you're a little bit worried, you might want to put out a MET call as the junior F1. Help around within the realm of the NHS, especially for an F1. You can ask anyone anything at any point. Some people might make fun of you, but the whole point is that's how you learn. Not that many people, I said some people. They'll be like, you should know that. So it was great. Learning aspect was absolutely fantastic. I was overwhelmed and scared a lot, but I feel like that's part of it. Again, I'm not trying to mansplain a lot of things. I feel like some people who are gonna watch this episode might not know a lot of medical lingo. So I'm gonna be very mindful, very demure, very mindful, very cutesy about the way I use terminology. You are really smart, probably smarter than me, so I don't need to mansplain everything or doctor-splain everything. Second rotation was something called geriatrics, so the study of old medicine. So anyone over the age of 65 classifies as a geriatric patient. On this rotation also, I got added to the on-call rota, which is just another word of you having to stay in the hospital longer than you should be. So the on-call rota, we'll get into that in a little bit. I did Jerry's by being on the on-call rota, meaning I didn't even go to my geriatric ward for the first month. I did another month of acute medicine. So everyone who's on the on-call rota as an F1 also does 1 month of acute medicine. It's also called the acute block. Remember what I was doing in 4 months of acute medicine? A lot of post-take. Remember the people I mentioned who were clerking, admitting? I was doing that now. Different for different people. Some people get it in 2 weeks, then they're on their home ward, then they do it again for 2 weeks at a later time. I got my whole month together. So I finished acute medicine the day, let's say, whatever it was, December 5. December 6th all the way to Jan 5th or whatever, I was doing my acute block. Instead of doing post-takes mainly, I was now doing a lot of clerking, a lot of admissions. There's different shifts. 1 to 8 shift, there's a 4 p.m. to 12 midnight shift. There's the long day 9 to 9 shift. And the long day shift is where you're part of the MET team. Remember I mentioned there was an F1 on the MET team? Yeah, I got to be that F1. Holding the MET leap, showing up to MET calls, expected to do very simple things like A to E assessment, airway, breathing, circulation, a disability, everything else, or exposure. Go on access. I got to learn a lot more of like skills like putting in cannulas, doing ABGs, which is an arterial blood gas, or a VBG, which is a venous blood gas, during these MET calls. It really makes you think on your feet, different than acute medicine where you're somewhat in a ward setting. In the MET team, your guys are like all over the place. So you'd be having a med call at like a cafe outside the hospital. It could be on like the main entrance of the hospital. It could be in literally one of the physiotherapy like centers. So it doesn't necessarily always have to be on a ward. You don't necessarily have all the equipment that you need. The acute block was great. I love clerking. I love being the admission doctor. Just because that's when doing acute medicine, you are living off second-hand opinions, as in the impression doctor, the clerking doctor will see the patient first. Then the consultant will see them, and you're the junior with the consultant. So you're like 2.5. You're like this person right here in my finger. And opinions are not entirely yours. Even though the consultant will try to weigh in some decisions with you, it's mostly their impression, and you're kind of going off that. Now, all this impression, when you're doing your acute block, is from me. I'm clerking. I'm the one deciding what the hell is happening. If someone comes in with cough, shortness of breath, and green phlegm, I'm thinking, okay, this is a chest infection. This is absolutely a chest infection. And then they have like things like confusion or strong smelling urine. I'm like, this is urinary infection. Or they have something completely random, like new weakness on one side, the right side of their body. So right-sided weakness on the leg, and left-sided facial droop, and left-sided dilation of the eye. And then you're like, whoa, is this a brainstem stroke? A stroke is basically when there's either a bleed in the brain or blood supply cut off to the brain. See how exciting this is? I went to med school for something like this impression. So that was really exciting the first time I did that. The first time I clerked someone properly was while I was in my acute block. On-call rota means also the days you're on your home-based ward, which is your 9 to 5. Some days you would be 5 to 9 as well. Meaning 9 to 5, and then 5 to 9, you're paired up with another F1, and you're doing something called a ward cover, meaning there's 2 F1s usually. On Mondays and Fridays in our hospitals, we have 3 F1s who are part of the ward cover team, as in the 5 to 9 after the 9 to 5. And then the rest of the days, there's 2 of you, there's 1 SHO on ward cover, there's 1 reg on the ward. So you, 4 to 5 people each day, are handling the hospital out of hours, the medical part of the hospital. You get a lot of funny calls. Some of the calls are as simple as, can you prescribe this patient paracetamol? They just came in there, or they're spiking a temperature. Can you prescribe IV paracetamol? What do you advise I should do? And then usually tell them, like, you know, the simple things like, oh, did they come in with an infection? If so, have we done a septic screen? Have we taken their bloods today? Have we taken some blood cultures? How have we given them some fluids? And sometimes you get even calls like, can you prescribe fluids? This patient is no by mouth, due for a surgery tomorrow, due for a procedure or a scan. And other times it's like, this patient is now newly confused, or this patient had a fall, can you come see them? And then you have a bleep. It doesn't have that many buttons. Oh, I finally found this. Look, guys, I can change the background. Okay. Do you guys like purple? It has 1 number on it. People can bleep you. It usually doesn't really have messages unless it's the med bleep. Then it has like medical emergency team system. When you're on ward cover, or the 5 to 9 after the 9 to 5, you're usually paired with someone. So it's good having a second set of eyes, second set of ears, and another brain. Sometimes you might not be certain what exactly is happening with the patient, and you usually go in pairs. At least that's what I would do when I was on ward cover. The person I was on ward cover with, we'd go together to see the patient. Unless it's something very simple, then we split up. Or if we have a lot of calls, we'd split up. I started geriatrics, the rotation for old people, or looking after old people. And that was a completely different place than acute medicine. Everyone is sick, but not that sick. There's a lot of social admissions. There's a lot of people with chronic problems, a lot of people with cancer, a lot of people were palliating. Palliation doesn't necessarily mean end of life. It means trying to make someone comfortable, someone who shouldn't be necessarily staying in the hospital. They should be in a home care setting where they're more comfortable. I learned a lot about the problems that a lot of the elderly suffer, you know, things like hip fractures, constipation, confusion, things like dementia, problem with people's memory, motor functions, Alzheimer's, Parkinson's. You saw these kinds of cases, and then you have to be very pragmatic when you're doing geriatrics, meaning your number 1 goal for this elderly person is try to get them home, try to get them into a care home, make sure they don't stay in hospital because their body's frail, their immune system is frail, they're more likely to get sick. So the longer they stay, the worse they get. Geri's in itself was very calm. It was also heavily supported by a consultant. My team was great, even though at every point in time, one of us was on an acute block, so I didn't get to work with everybody all the time. But I had a great team. We were 3 F1s on our ward. Not everybody was in every day. We were 1 IMT, which is an internal medicine trainee, and 1 consultant. And we also have something called an ACP, which is an advanced clinical practitioner, which is a nurse who is now specialized, taking the training to be a specialist, doctor-esque kind of person on the ward. Really sit down, have a lot of emotional conversations with families, with patients, discussing resuscitation or not to resuscitate, making decisions about end of life. I said it was fun, but I meant like learning aspect, it was fun. It was also always really sad. The first time I really cried and broke down was during one of my cherries rotations, where someone I knew for 3 weeks and then they died. They were like my patient. So I got really emotional with that, you know, like they were under my care, and obviously this was imminent, it was meant to happen, but it was still pretty sad. Jerry's for 4 months, got to learn a lot about the elderly and just the problems that they face, the social aspect of things, the aftercare after the hospital, physiotherapy. Last rotation was a surgical rotation called trauma and orthopedics. So everyone who hit their head, everyone who broke a bone will come under trauma and orthopedics. To be honest, I am not surgically inclined. I'm a medical guy. Give me a stethoscope, ask me to request scans, ask me to interpret bloods. I would do that for days. That's my bread and butter. I do not want to be a surgeon. I do not want to do orthopedics. I'm holding a sword. Imagine me just like this in your bone every day. It can't be me. It wouldn't be me. But the best team I had by far in my F1 year was my orthopedic team. Shout out to anyone who would watch this from my orthopedic team. We were 4 F1s, 4 F2s, a couple of ACPs, and loads of consultants. The nursing staff was great. The healthcare staff was great. The rest of the team was great. I'm not saying it was just the doctors that made this rotation great. It was literally everyone on the trauma ward made this experience really wonderful. We really felt like a family. I would come into work, I'd be so happy to see the other doctors, I'd be so happy to see the consultants, anyone else, you know, the nurses, the healthcare staff. I knew most of the people's names. They knew my name. They called me handsome Dr. Bilal. I'll make that up, that's true, you can ask any of them. Orthopedics, what I got to learn, a lot of things that you would learn now in acute, going back to acute medicine or the acute block, sometimes you admit people who came with like leg pain or like back pain or their arm is a bit out of whack. You would refer to orthopedics, and now you're on the opposite side of the spectrum where you're the people they're referring to. So you saw a lot of people with broken bones or soft tissue infections or rib fractures, head injuries, brain bleeds. The consultant support in orthopedics is great. They know a lot about general medicine as well as surgical medicine. You got to go into theater, you got to scrub in, see what it's like firsthand to do a hip replacement or a knee replacement, even though you're mostly holding retractors. The exciting thing you could do is suture someone closed. But that was a great rotation. I got to learn about different types of imaging, so x-rays and MRIs, CT heads. I would look at a lot more in this rotation than any other rotation so far. In medicine, you're mostly looking at things like chest x-rays. Those are the only plain films you'd be expected to interpret, and then things like CT scans and MRI scans you would usually wait for the report, because the radiologist is specialized and they're the ones who should be telling you what you're seeing rather than you having to put all your brain cells, because I'm not a specialist radiologist, I'm just a general medical doctor. I got to learn a lot about how a knee replacement should look like, how hip replacement should look like, displaced fractures or just some angulation or a little comminuted fracture. It was great. We had a lot of events or like socials under the orthopedic team where we went out with the consultants and alike. That was a lot of fun times. I had a great time in ortho. There was something to learn from each different rotation. Acute medicine was all pure medical stuff, pure acute conditions, things like pulmonary embolism, which is a clot in the lungs, myocardial infarction, which is a fancy word for a heart attack, simple things, chest infections, gastroenteritis, diarrhea, vomiting, urine infections. Jerry's was a bit more calm, a bit more relaxed. You got to learn a lot about the social aspect of admissions, a lot of safeguarding concerns. Safeguarding is respecting a patient's autonomy and struggles that they might be having, meaning someone's husband is abusive to them when they come onto the ward, or someone has problems with their children at home and their medications and things on time. So you got to learn, you got to be pragmatic, you got to be learning about the aftercare, like I said previously. And orthopedics is essentially any kind of trauma I would have wanted to learn. I got to learn greatly under an amazing team. Ortho especially, I got to see a lot of the same, you worked first hands with the F1 and the F2s and the ACPs, and the consultant changed every week. And the nursing staff and the healthcare staff stayed essentially the same. I have a lot of good friends from my current closest friends, probably after my own group of friends that you guys probably see on Instagram all the time, my Prague gang, is my team from orthopedics. I'm quite close to them still. 1 year. Near the end of F1, it was quite stressful time because, like I said, like the local people or the locals who do F1 here, the Brits, they get F1 and F2 assigned together as a pair. For the clinical fellows and the international medical graduates, we need to apply for a separate job. So again, track applications, NHS job. I started my F2 year here. I'm now an SHO, a senior house officer in acute medicine. It's a lot different than F1. It's way more overwhelming, but it's okay. Learning is always good. This is what it takes to be a doctor. I'll post another video a year from now about my experience in F2. I've made a lot of friends. I have a lot of good memories from my F1 year. I've learned so much. A lot of you who are in med school now might be thinking, oh, I don't know this, I don't know that. Trust me, I didn't know anything. well, not anything. I knew a lot of theory because in my university they're very theory heavy. But the clinical aspect of being a doctor, how to think critically, how to for situation, knowing that you have support around is so helpful, and you learn that on the job. So don't feel overwhelmed if you don't know much, or if you feel like you're lacking behind or you're falling behind. There's a great support system, literally not just from all the other doctors, from literally anyone in the hospital. You have a type of support. Never think you're above anyone or below everyone. You're all the same playing field. We're all one big family, and we're here to help out the patients that come into the hospital. Remember, you're treating the patient, not the disease. So make sure to talk to them, make sure to have conversations. A big part of being a doctor is communication. It's not just being really smart, it's not just knowing how to do certain procedures. It might not be as interesting to everybody else, but this is something that I always wanted to talk about, and I was waiting to finish before I wanted to speak about it, just so I had like a bit more of an insight. Some of you might be more interested in medicine, others might be more interested in surgery. Sorry, I'm slurring my words. If you ever need help with anything, or anything about an F1 year or some of these rotations I spoke about, feel free to message me. I'm always happy to talk. And I would love to just answer your guys' questions if you have any, because I sure did before I started and while I was here. I was constantly nagging my seniors who are already working in the NHS, getting some insight from them. If you guys just ever need help talking about anything else in general, whether that's not related to medicine but still about the NHS, I'm happy to answer some of those questions too, even though I might not be the best person. I have a lot of friends that are nurses, so if anybody wants to know about that, I can surely put you to the right people. Anything about being just a doctor starting off, I'm happy to answer, happy to how to look into these things and how to get into this kind of stuff. I'm not an expert, but I'm happy to help. This video is 7 more hours left, I believe. I've been taking up a lot of your guys' time. I hope you enjoyed this episode. It was a bit of a different one. Not for everybody, like I said, people who are interested in working as a medical professional. I hope you garner something from this. Well, it was just my own experience rather. I didn't really go much into the day-to-day that much, but I think I gave a general understanding of the 3 rotations I did and my general experience as a Foundation 1 doctor. Like and subscribe. I'll try to make more frequent episodes. I say this every time. But a new episode comes out like every couple of months, so it's not gonna be a weekly thing. I still don't have that much time. But I try to make the most of it. You know, you do get a lot of breaks, so don't feel really overwhelmed. You do get to go and hang out with your friends. You do have time to go to the gym, like, you know, mental health things. You do get time to see people, and you can make the time. It's just in the start it's overwhelming. For the first couple of months you might not want to do anything and just go home and be in your bed, and that's okay. That's freeze fatigue or whatever it's called can happen. And if you ever need help with that, you know, like I said, once you start, feel free to message me or talk to me. This has been your boy Bilal from the GoliCast. I'll talk about something a bit more exciting next time, something that's a bit more appealing to all kinds of audiences. But see you guys later. Take care. Adios. Sayonara. Nascedano. Au revoir. Buongiorno. Grazie. I don't speak Italian either.